Alyssa Dahl is a breast surgeon with the Norton Surgical Specialist Breast Health. She got her medical degree from the University of Louisville School of Medicine. She did a general surgical internship and residency at the University of South Alabama in Mobile. And then she went out west to California and did a breast surgery fellowship at the University of California, Los Angeles. She'll be presenting axillary surgery and breast cancer, evolving standards in surgical decision-making. Welcome, Dr. Alyssa Dahl.
Good morning, everyone. Thank you so much for being here. It is my pleasure today to talk about axillary surgery in breast cancer, evolving standards and surgical decision-making. So I have nothing to disclose. So axillary surgery for breast cancer in 2025 and treatment for breast cancer in general is within an era of de-escalation. And so we've seen this de-escalation from axillary lymph node dissection to sentinel lymph node biopsy over the past 20 years or so. And now we're starting to see de-escalation even further to include omission of axillary surgery in general in well-selected patients. So these are some things I'm going to talk about today. I am going to focus on some early stage breast cancer. I'm going to briefly go over just some guidelines and focus time on where some new research has kind of developed. And I think that those two places that are notable are patients with a node negative axilla and also in patients who are clinically node positive and then receive neoadjuvant chemotherapy. So before we jump into sound and enzema, a little bit of background. So the Choosing Wisely guidelines or the Choosing Wisely campaign has encouraged breast cancer providers to start de-escalating axillary surgery. And so where we've started is women in 70 years or older who have small, early stage, better biology breast cancers to start de-escalating axillary surgery in those group of patients. Choosing Wisely really considers patient 70 above, and then these trials published more recently in 2023 and 2025 expand some of those patient criteria. I mentioned these two trials together because they're very similar, and so we can see some of the similarities and differences between them here. But the SOUND trial included 1,400 women with clinical T1 invasive breast cancer. Patients were undergoing breast conserving surgery and were recommended for whole breast radiation following. Patients had clinically negative lymph nodes, and importantly, they had a negative axillary ultrasound. These patients were randomized 1-to-1 to sentinel lymph node biopsy versus no axillary surgery. Enzema was similar in what it investigated. There are a couple key differences. There were more women, 5,500 women, and they expanded to include patients with T1 as well as T2 breast cancer. 90% of patients in the enzema trial did have T1, and so that is where the push and kind of the focus is in these. Similarly, they were patients that were undergoing breast conserving surgery recommended for whole breast radiation and had clinically negative lymph nodes with a negative axillary ultrasound. They were randomized 1-to-4 rather than 1-to-1. A similarity between these two trials is that patients in both were very likely to have hormone receptor positive and HER2 negative disease. This is really where we're focusing a lot of these efforts of de-escalation is in patients with early stage hormone receptor positive and HER2 negative breast cancer. And so the findings, so for the SOUND results, here you see the survival curves for distant disease-free survival, disease-free survivor, and overall survival. In the orange or the lighter color, that is in patients who did not undergo axillary surgery, and then the darker line is patients who did undergo axillary surgery. And you can see crossover of these lines, suggesting that there is no difference between the two in terms of axillary surgery versus no axillary surgery. This trial, as well as the enzema trial, they are both non-inferiority trials, which means that they're not looking for is no sentinel lymph node biopsy greater than, but is it non-inferior to omission? So something that I think is also really interesting is that in the sentinel lymph node biopsy group, 13.7% of patients had nodal involvement. In a randomized trial, we can extrapolate that same risk or that same rate of involvement probably exists in the no axillary surgery. So despite that, and despite extrapolating that there's probably a decent percentage of patients that have axillary disease microscopically and are not undergoing axillary surgery, there was a low rate of nodal recurrence. And so I think this is a trend that we see in much of our research is that is that microscopic disease in the axilla isn't necessarily a surgical problem as much as it's a systemic problem. So this trial concluded that omission of axillary surgery was non-inferior to sentinel lymph node biopsy. So again, that non-inferiority is very important. So for Encema had a median follow-up of just over 6 years, and the primary endpoint was 5-year disease-free survival. So those two numbers you can see are almost identical. So 91.9% in the no axillary surgery group and 91.7% in the surgery group. They did note a slight difference in axillary recurrence and the death rate between the two groups. They don't go into much detail about the thought of those. But the 5-year disease-free survival was very similar between those two groups of patients. There was lower rates of lymphedema, greater arm mobility, and less pain in the no surgery group. And so this really supported the same thing sounded in that omission of axillary surgery provides safe oncologic outcomes, and there's also fewer side effects when you're able to omit axillary surgery. So the ASCO guideline update in April 2025 kind of brings in these two trials, and it really personalizes it to a very specific subset of patients. So again, we talked about that the majority of patients in these trials had early stage, so T1 breast cancers, and were hormone receptor positive, HER2 negative. So these updated guidelines say that we do not routinely recommend sentinel lymph node biopsy in patients who are postmenopausal, over the age of 50, with a negative axillary ultrasound and clinically node negative for good biology, so grade 1 to 2, early stage T1, hormone receptor positive, HER2 negative breast cancer. The key here is that they're patients that are going to be having lumpectomy and radiation. And so that brings up an important question is, if a patient is going to be having a lumpectomy, we are also trying to de-escalate in other treatment modalities. So radiation is something that comes up a lot. And if we omit axillary surgery, are we maybe not allowing patients to omit other adjuvant treatments or to de-escalate those other treatments? And this discusses that as well, so I kind of alluded to this, but PRIME 2, just worth a brief mention, I think, is a trial that included 1,300 women over the age of 65 with, again, this small early stage breast cancer who were receiving breast conserving surgery and endocrine therapy, and this really looks at the addition of radiation. The two arms in this study were whole breast radiation versus no irradiation, and the survival rate between the two groups was the same. There was decreased ipsilateral breast tumor recurrence in the radiation group, but what this trial has encouraged us to consider is that in select patients, radiation following lumpectomy may be omitted without affecting survival. The key here with axillary surgery is that patients in this study had a negative sentinel lymph node biopsy. And so sometimes, as we're trying to de-escalate in the axilla, we have to be mindful of how that's going to affect our radiation colleagues as they're recommending adjuvant treatment. I do want to just discuss briefly, just for completeness sake, some of these other subsets of patients. This is not newer data. This has been around for some time, but drives how we treat these patients. So the next subset of patients is patients who are clinically node negative, but have a positive lymph node on sentinel lymph node biopsy. Before these trials, the standard of care was that any disease in the axilla needs to be treated with an axillary lymph node dissection, which is removal of all of the lymph nodes, rather than a sentinel lymph node biopsy, which is removal of the first draining lymph nodes, usually between 1 and 5. And so these two trials, Z11 and Amoros, looked at that, basically asking the question is, if somebody has 1 to 2 nodes positive on pathology at the time of surgery, do they need a full axillary lymph node dissection? These are patients, again, that had T1 to T2, so we're seeing a little bit of a trend. Clinically node negative, and this is important. This is before the widespread use of axillary ultrasound, and so clinically node negative was no palpable disease. Z11 included patients only that were undergoing breast conserving surgery, and Amoros expanded that to include patients that were undergoing mastectomy as well. Z11 looked at sentinel lymph node biopsy compared to sentinel lymph node biopsy followed by axillary lymph node dissection, and Amoros compared lymph node dissection to axillary radiation. And so on the left, we see the overall survival, the results from Z11, which shows that those two curves overlap, signifying that there is not a benefit to more axillary surgery in those patients who have small volume disease. And then on the right are the results from Amoros. This is disease-free survival. And again, you see that those two curves between axillary lymph node dissection and axillary radiation overlap. And so these were the conclusions from these trials. So from Z11, even when a small amount volume of disease exists within the axilla, more surgery does not lead to an improvement in survival. And this is something we're seeing over and over again in breast cancers with regards to the axilla. Multiple trials have shown that a small volume of disease in the axilla really, we should consider more of a systemic problem in systemic treatments rather than surgery, because it really is not going to be possible to remove every cancer cell. And at that point, if it's in the axilla, we have to question, how do we protect the body? For Amoros, the main takeaway from there is that axillary lymph node dissection is non-inferior to axillary radiation with respect to disease control. And importantly, another trend we see is that avoidance of more aggressive axillary surgery leads to better quality of life, lower rates of lymphedema, and less pain when you compare that to axillary radiation. Another brief mention is our patients and what is our standard of care around patients who have, say, limited involvement. So there have been questions in recent years in patients who are clinically negative, meaning you do an exam and you don't feel any lymph node involvement in the axilla. But as our imaging has improved, we sometimes find abnormal nodes on imaging that we don't feel on exam. So the question is, how do we classify those patients? Are they clinically positive, or can we put them into a negative node category? And this is the NCCN guidelines as of this year, and they suggest that these patients can be treated with sentinel lymph node biopsy alone as long as that disease burden is relatively limited, compared to those patients who are clinically node positive. So again, this is based on exam, and in general, if those patients are undergoing upfront surgery, which a lot of times is based on not only stage, but tumor biology, that axillary lymph node dissection is recommended in upfront surgery for those patients with palpable disease. There are some trials that are looking at this right now, and I think that this is going to be an interesting point to revisit in the next 5 years or so. Taxus is a trial that is looking at tailored axillary surgery, which is removal of biopsy-proven positive lymph nodes, any palpable nodes, and sentinel lymph nodes, and comparing those long-term outcomes to patients who have an axillary lymph node dissection. So in this idea of de-escalation, I think we're going to continue to see this, really tailoring treatment to provide great benefit while also hoping to minimize the side effects of aggressive axillary surgery. Another area that is really gaining a lot of attention recently are patients that are clinically lymph node positive and then undergo or receive neoadjuvant chemotherapy. There are 2 trials that have really been revolutionizing the way that we see these patients. And as our systemic therapy has gotten so much better and we're seeing increased rates of PCR in our patients, this is really a consideration. So the question becomes, if somebody has a really great response, what is the need to be really aggressive in terms of our axillary surgery? Do we need to subject those patients to high morbidity operations? And what's the benefit? And so the first trial that investigated this was the ECOSOG Z1071 trial. And the way that this was designed was actually to evaluate the false negative rate of sentinel lymph node biopsy after neoadjuvant chemotherapy. So there's a little bit of thought that chemotherapy can disrupt the lymphatics and the lymphatic flow, and that the sentinel lymph node biopsy would then not be accurate following neoadjuvant chemotherapy. And this was actually a negative trial. So they used a 10% false negative rate as their cutoff for being an acceptable false negative rate. And sentinel lymph node biopsy alone actually didn't meet this, but this trial found that addition of certain things, so dual agent mapping, which is the combination usually of blue dye as well as a radio tracer, helped to decrease that false negative rate, as well as the removal of at least 3 nodes. That has kind of changed our practice in patients that we are doing axillary surgery after neoadjuvant chemotherapy. That is our goal. We want to make sure that the axilla is well sampled so that we can really rely on those sentinel lymph node biopsy results. This other study by Caudle et al. Looked at the false negative rates in, again, patients who are clinically node positive and received neoadjuvant chemotherapy. Sentinel lymph node biopsy alone, again, was above that 10% threshold. That dropped significantly when we added the retrieval of the clip nodes. The false negative rate dropped significantly. And what the retrieval of the clip node is before chemotherapy, the lymph node is biopsied and there's a clip that's left in there. So when you're doing the surgery, somehow targeting that lymph node to assure its removal can give us a lot of information in terms of response. When you add retrieval of the clip node and sentinel lymph node biopsy together, that has the lowest false negative rate. And so that is most commonly what I do in my practice in these patients. In patients who have neoadjuvant chemotherapy and don't have a good response, the recommendation is still for axillary lymph node dissection. And that also actually exists if they have clinical response but still are pathologically positive. So maybe not on clinical exam, but under the microscope. Again, I think there's going to be more interesting data to come in the next 5 years from Alliance 11202 and the Taxus trials. But for now, this is where we are. So this is just a summary of things I've talked about so far, but I really want to emphasize the importance of a multidisciplinary approach before de-escalation of axillary surgery. So it's really important to discuss with our medical oncology colleagues and our radiation oncology colleagues about how de-escalation in the axilla affects their treatment. Because ultimately, if we're de-escalating surgery just to escalate another treatment modality, maybe it isn't worth it. We discussed this a little bit already, but in postmenopausal women over the age of 50 with small, good biology tumors, who have a negative axillary ultrasound, we can consider omission of sentinel lymph node biopsy if it's not going to change adjuvant treatment. Pathologically positive sentinel lymph node biopsy, maybe those patients can still have a sentinel lymph node biopsy if only a few are positive. Limited nodal disease, those patients generally can also have sentinel lymph node biopsy, but with palpable disease, axillary lymph node dissection is recommended. And again, patients with a good response after neoadjuvant can be considered for a targeted axillary dissection, which is that lymph node biopsy with removal of the positive node, remembering that for residual disease, axillary lymph node dissection is recommended. Axillary surgery is complex. I think it's evolving, especially as a part of the multidisciplinary team, but this is just the ASCO guidelines. It's there for your reference, but thank you guys so much for your time. I would be happy to take any questions.
Thank you very much, Dr. Dahl. That was really very enlightening for me. I came from the surgical era when they were still arguing about mastectomies, lumpectomies, and all of that. So it's really come quite a ways. I'm now going to introduce Dr. Blakely Cute. She's a medical oncologist with her group, and she graduated magna cum laude from the University of Louisville School of Medicine. She did her internal medicine residency at the University of Alabama at Birmingham, and then did a fellowship in hematology and oncology at the Brown Cancer Center here at U of L. After that, she was at the Ochsner Clinic in New Orleans, where she subspecialized in breast cancer at the time. She did clinical trials and did education for medical students and residents. Welcome, Dr. Cute, to speak on systemic strategies in breast cancer. Dr. Cute.
Good morning. So, as Dr. Ham said, I'm Blakely Cute. I specialize in breast cancer. I have scaled down the talk to just cover a few topics on HER2-positive breast cancer. So I'm going to try to cover 3 abstracts that were presented in 2025, 2 in the metastatic realm, and then 1 in the early breast cancer realm. I'm going to start our first 2 abstracts with patient cases to try to make it more applicable and so that we can understand how we could use this in our own clinic. So this first patient is a 52-year-old female with HER2-positive metastatic breast cancer. She was initially diagnosed as a stage 2 breast cancer, received our standard treatment with neoadjuvant TCHP. She had 5 millimeters of residual disease at the time of surgery. She went on to complete TDM1 and radiation therapy, and then 18 months later has recurred with liver and lung metastasis that is biopsy proven HER2 positive with an IHC of 3+ and hormone receptor negative. She has no brain metastasis. So Destiny Breast 09 is a clinical trial that's evaluating first-line trastuzumab deruxtecan with or without pertuzumab, compared to our current standard of care of a taxane with Herceptin and pertuzumab. The outcomes for patients with metastatic HER2-positive disease have dramatically changed since trastuzumab deruxtecan was approved in the second-line setting, and at that point it showed an unprecedented 29-month progression-free survival benefit. And since that time, we've wanted to see, could we move this drug forward into earlier line settings? And that's what this Destiny Breast clinical trial is evaluating. The primary endpoint was progression-free survival. So there was an interim analysis performed, which was only, when we presented it, it only showed the trastuzumab deruxtecan plus pertuzumab arm compared to standard of care. The pertuzumab, or the TDXD arm alone was not presented. Median age was 54. More than half of the patients had de novo metastatic disease. About half of the patients were hormone receptor positive, and majority of patients were HER2 positive by IHC alone. Approximately 43% of patients had prior chemotherapy and 30% had prior targeted therapy. Interestingly, only about 8% had prior pertuzumab. So at a median follow-up of 29 months, the median progression-free survival for trastuzumab plus pertuzumab was 40 months compared to 26.9 months in the standard of care arm, which is about a 14-month benefit. This was seen across all subgroups. At 2 years, 70% of patients on trastuzumab deruxtecan plus pertuzumab were still on therapy and remained progression-free compared to 52% on our standard of care arm. Our secondary efficacy endpoints, we see that 85% had objective response with trastuzumab deruxtecan and pertuzumab compared to 78.6%. We also see that the median duration of response for the trastuzumab deruxtecan and pertuzumab was 39.2 months compared to 26.4 months. There were no new safety issues seen, and our side effects were what we expected within these medications. There were 5 possible treatment-related deaths, however, with the trastuzumab deruxtecan arm. Our most frequent side effects you can see here, mainly nausea, vomiting, and neutropenia, as well as fatigue. And in conclusion, ultimately, it's felt that Destiny Breast 09 clinical trial that with TDXD plus pertuzumab, it demonstrated a clinically meaningful and statistically significant improvement in progression-free survival compared to our taxane, Herceptin, and Perjeta, with a median progression-free survival of 40.7 months compared to 26.9 months. The progression-free survival benefit was seen across the pre-specified subgroups. Other efficacy endpoints, we did have a complete response and early overall survival data showing benefit as well. The safety profile was without any known side effects, and investigators concluded that this could represent a new standard of care for first-line treatment of patients with HER2-positive metastatic breast cancer. So back to our patient case, this patient went on to enroll in clinical trials. She was randomized to trastuzumab deruxtecan and pertuzumab arm. She had imaging per protocol. She had a partial response at her first set of imaging, along with symptom improvement. With time, she maintained this response for 40 months and then progressed and was able to move on to second-line therapy. So clinical thoughts regarding this trial. The first one is, can we stop trastuzumab deruxtecan and move plus pertuzumab and move to maintenance therapy? We know in patients that follow the Cleopatra regimen, so get the taxane, Herceptin, and Perjeta, that after 6 to 8 cycles of the taxane, we can stop and maintain them on Herceptin, Perjeta, and they have fantastic quality of life. So we hate to subject patients to worse quality of life despite better outcomes if we don't have to. So a big question is can we at some point switch these patients over to maintenance therapy? We also have to evaluate, they say this drug is tolerable. Everyone's tolerability standard is different depending on what their goals of therapy are. So it's just a discussion that we have to have with our patients before we start this. We also want to know what is the true overall survival benefit with sequencing trastuzumab deruxtecan first line compared to second line? And then personally, I'm wondering could trastuzumab deruxtecan plus Perjeta be most appropriate for use in those who have active brain metastasis? Those were excluded from this trial, but we know that trastuzumab deruxtecan has excellent CNS penetration. So I think there's real potential to select those patients that really could benefit here. So we're going to move on to our second abstract and our second clinical case. This is a 37-year-old female who had HER2-positive, hormone receptor-positive metastatic breast cancer. She presented with left breast fullness while nursing that was large on the left compared to the right. Diagnostic imaging confirmed a 42 millimeter left breast mass and an axillary lymph node. She had an MRI, which showed the known breast disease as well as a suspicious sternal metastasis. Subsequent imaging confirmed an FGG-avid liver lesion as well as the sternal lesion, and sternal biopsy confirmed metastatic triple-positive breast cancer. She went on and received the Cleopatra regimen with Taxotere, Herceptin, and Perjeta, completed her 6 cycles in the end of January 2025. She went on to start maintenance Herceptin and Perjeta and tamoxifen. She declined ovarian suppression and AI therapy. The Patina clinical trial was presented at San Antonio Breast Cancer Conference last December 2024 while she was wrapping up her induction therapy. Patina is a phase 3 clinical trial evaluating the addition of palbociclib to maintenance anti-HER2 therapy plus endocrine therapy. Palbociclib is currently it's a CDK4/6 inhibitor that we use in hormone receptor positive, HER2 negative metastatic breast cancer. It's generally well tolerated. So in this clinical trial, patients had to have completed the Taxotere or the taxane portion of their chemotherapy and had to have at least stable disease on their imaging before they were randomized. The primary endpoint was progression-free survival, which had a median follow-up at 53 months. We saw that there was a significant improvement with palbociclib, improving progression-free survival by 26%, with a median progression-free survival in the palbociclib arm of 44 months compared to 29 months in our current standard of care arm. Palbociclib is generally well tolerated. There is significantly more grade 3 neutropenia. However, in general, this neutropenia is well tolerated without significant neutropenic fever. Overall survival data remains immature, however, the median overall survival was not reached for the palbo arm, but was 77 months for our current standard of care arm. So in this patient case, we're really trying to balance, she's also trying to incorporate same complementary medicine, wanting to kind of try everything as a 37-year-old with 2 young children. She did it. She wanted to add palbociclib, which we did. So her imaging before we added palbociclib showed a partial response to her induction chemotherapy. So she then started maintenance, Herceptin, Perjeta, tamoxifen, and palbociclib, and her current scans have showed no active disease. She's tolerating her regimen very well. So implications for this trial, it's incredibly meaningful. It could add an extra 15 months. Data suggests that palbociclib could overcome anti-HER2 and endocrine therapy resistance. Trial also shows that these patients live a long time, and because they're living so long, it's important that we try to maintain their quality of life. And we know that if we can keep them on maintenance Herceptin, Perjeta without more cytotoxic therapies, they do have good quality of life, potentially for up to 4 years, like this trial is showing. So to summarize, on the right side, you'll see our standard of care, and I won't go over that, but on the left side, you will see some of the things that we talked about. So we have potential the trastuzumab deruxtecan with or without pertuzumab, potentially moving into first-line therapy. And then over here, we also have future maintenance options, including tucatinib, palbociclib, oral SERDs, and PIK3CA inhibitors. So one more that I'm going to try to get through is the NeoCARP clinical trial. This is not in the metastatic setting. It's in the early breast cancer realm. We know that our current standard of care is TCHP, so it's a taxane plus carboplatin plus Herceptin plus pertuzumab. We know that it has high efficacy, but it's also significantly toxic. So we can see a pathologic complete response rate anywhere from 55 to 65%. But we oftentimes have treatment delays, maybe treatment cessation because of the toxicity with these medications. We, in the metastatic setting, have seen that the addition of carboplatin to Herceptin and docetaxel did not show overall survival benefit. And so we wanted to see, could we potentially de-escalate in this study. So in this study, where it is, as Dr. Dahl was mentioning, this is another non-inferiority clinical trial looking to see, can we do Taxotere, Herceptin, and Perjeta without carboplatin. These patients were randomized, again, to our standard of care. These were stage 1 and 2 patients, standard of care or chemotherapy without carboplatin. Our primary endpoint was pathologic complete response. Median age was 52. We were pretty well-balanced between pre- and postmenopausal patients. A third of these were hormone receptor negative, and majority were HER2 positive via IHC of 3+. Slight difference here is about 35% of the patients used docetaxel, which is what we use mainly here in the United States. So we use a slightly different backbone than what most of these patients had in this trial. Toxicities, the carboplatin-free arm had significantly less grade 3 and 4 hematologic toxicities, most notably decreased neutropenia and decrease in nausea and vomiting. We also see that the pathologic complete response was similar between the carboplatin-free arm and the carbo arm at 64% versus 65.9%. To the right, we have some subgroups, and we see that they're fairly equal responses in both subgroups. So clinical thoughts, Taxotere, Herceptin, and Perjeta, or a taxane, Herceptin, and Perjeta provides comparable efficacy to our standard TCHP with improved tolerability. It may reduce overtreatment. However, I think we have to really just adopt this in select patients. So we have to remember that most of these patients were stage 1, stage 2, and stage 3. And I think that we have to, so for me, what I'm kind of adopting this in patients who are somewhat older, who have earlier stage disease, who may not be able to tolerate full TCHP. Other times is if patients who are younger and are not tolerating treatment well, my first thing to dose reduce, and I've been doing this for a while, but the carboplatin is the first thing that comes down or comes out of that regimen. So if we have some time remaining, I think we might, I will cover, this is just a drug that I think is kind of exciting. GLSI 100 is a drug that's received fast track designation from the FDA based on ongoing data from the Flamingo 01 clinical trial. This drug is assessing whether extended adjuvant therapy with GLSI 100 can improve invasive disease-free survival in HER2-positive breast cancer patients. These patients had to have completed all of their adjuvant therapy. So they've done neoadjuvant, surgery, adjuvant, completed their year of Herceptin and Perjeta, or completed their year of Kadcyla. And then they're randomized, well, they're tested to see if they have something called an HLA-A2 positive breast cancer. And they had to either have residual disease in stage 2, or they could have a pathologic response if they were stage 3. And then they received this GLSI 100 injections for 6 months in a fairly regimented dose, and then they go on a less frequent dosing over the next 2.5 years. This data is super interesting because it's based on a phase 2b study in which no recurrences were observed in the GLSI 100 group compared to 89% in the standard of care group. So this is super exciting. We're not close to it coming into clinical practice yet, but anytime we can see decreased recurrences in these patients is fantastic. And I'm just going to end, when I graduated from UAB for residency during our senior talks, we always ended with, everyone ended with pictures at the end. I came across some pictures from my residency years a while ago. When we're trying to keep our head above the water. On the far right, you can see our daycare masking taped reminders to our children so we wouldn't forget. So my kids were in our call room quite often, lots of meals, lots of climbing in closets, jumping on beds. And then here we are this year, they're old. One went off to college and one drives, and my husband's finally taking a deep breath. So there we are. Does anybody have any questions regarding HER2-positive breast cancer? All right, we'll pass it on to Dr. Ham and Layla.
Thank you very much, Dr. Cute. Layla Agrawal is a hematologist and oncologist who earned her medical degree at the Indiana University Medical School. She completed her residency in internal medicine at WashU in St. Louis, and then did her fellowship in oncology, hematology at Vanderbilt University, Nashville. She was inspired by her mother, who is a breast cancer survivor. Dr. Agarwal was drawn to medicine at a young age and specifically to oncology at that age. She strives to get to know every patient and learn what is important in their lives, from their families to their goals, and how that plays into important decisions about their health. Dr. Agarwal specializes in treating breast cancer patients and is involved in research and clinical trials. I had the pleasure of hearing Dr. Agarwal this summer in June at the ASCO annual meeting. It's a big 40,000 person meeting where kind of the best and the brightest get to present. Well, Dr. Agarwal was asked to chair a session on sexual health in patients called Let's Talk About Sex. And there were probably about 500 people in the audience. They were highly engaged, and the question just went on and on afterwards. So I thought, well, that would be a perfect talk for this group. So Dr. Agarwal.
Thank you so much. Thank you so much for that lovely introduction. So here at Norton, in addition to treating patients with breast cancer, we've also built what's called a sexual health program, right now focused on women diagnosed with any kind of cancer, as well as people who I call previvors. They may have a genetic mutation and undergo some of the same surgical treatments or otherwise resulting in sexual health changes. And so through the work that has been supported through Norton Cancer Institute, as Dr. Ham mentioned, I was here are my disclosures. I was very honored to be able to chair this session at ASCO this year. And we had co-panelists, Dr. Liz O'Riordan, who is a breast surgeon from the UK, came for the panel. She's a breast surgeon, but also a breast cancer survivor. And through her own experiences has been extremely, she really has advocated for incorporation of sexual health and survivorship concerns. And then Dr. Lawrence Jenkin, who's a urologist, gave a fantastic presentation on how to address male sexual health concerns after a cancer diagnosis. And along with the session, we also published a chapter in the ASCO educational book. So I would highly encourage you all to read that, because we really tried to break it down in a very clear and understandable way, and that's free and available online. So what I'm going to talk about today is that sexual dysfunction is really prevalent and it is distressing in female cancer survivors. And today we heard about all these fantastic advances in cancer, new breakthroughs coming down the pipeline all the time. But also it is so important that we consider our patients' quality of life and understand how fundamental many aspects, including sexual health, are to quality of life. The second point is that discussion of this sexual function should occur before, during, and after active treatment, and that we have what I call biopsychosocial interventions that can improve sexual health. So for women diagnosed with cancer, we know these changes are incredibly prevalent. We see sexual health concerns in 75 to 90% of breast cancer survivors, up to 90% of GYN cancer survivors, 75% of female colorectal cancer survivors. This is very prevalent after female patients undergo stem cell transplant, and even in tumors such as lung cancer, 77% of women diagnosed with lung cancer will have concerns related to sexual health. So we see this across the board, regardless of tumor type, and it's something that we can all be talking about with our patients. So we conducted a study together with a gynecologist and another oncologist about what is going on today, what is the experience that women with breast cancer are having with sexual health. And in our survey, which was an online survey, we found nearly 90% of our respondents said that breast cancer diagnosis or treatment caused a moderate to great deal of change in their sexual health. And importantly, 85% said this caused distress. So not only are people experiencing this, but it's really impacting them as well. And the majority didn't get information from their healthcare teams. And of those who said they did talk about it, the patient themselves was the one to bring it up. And so this is really where I think we can make a change and really impact this conversation. So I'm gonna go through a case. This is a hypothetical case that I've put together from really common issues that I see among our patients. So this particular one was a 40-year-old woman. She had stage 3 breast cancer, which meant she underwent neoadjuvant chemotherapy, bilateral mastectomy, she had radiation, and she's now on endocrine therapy with ovarian function suppression and aromatase inhibitor. And when she came in, she said that she and her husband had not attempted to have sex since her diagnosis, but they recently did, and it felt like razor blades were cutting her and penetration was impossible. And this sounds dramatic, but I hear this over and over and over again from our patients, and this is what many people are experiencing. They were both terrified to try again because of the pain, and she said, I had no idea cancer would take away my ability to have sex. And so I think this is just so impactful, kind of understanding the profound impact that these changes can have on our patients. So when we're thinking about sexual health, this is best done through what's called a biopsychosocial framework, which means that we know there's physical things, mental and emotional things, and social factors that all come together that influence a person's experience with sexuality. And when someone is diagnosed with cancer, all of these domains are affected. In the physical realm, we have hormonal changes, menopausal symptoms, genitourinary syndrome of menopause. With pelvic radiation, people can get something called vaginal stenosis, narrowing or shortening, or even agglutination of the vagina. After certain other surgeries, people may have an ostomy. There might be loss of nipple and breast sensation. Many patients might have fatigue, shortness of breath, issues with sleep. And then sexual response is considered desire, arousal, orgasm, and that's really multifactorial among all these domains. They may also be dealing with concerns about body image or fear of recurrence or other mental health issues. And then on the social side, their partners going through their entire own experience with having a loved one being diagnosed with cancer. They may have their own medical, mental, or sexual concerns as well. There can be loss of intimacy. There can be issues with communication. So this is what, when a patient comes into our clinic room or clinic, these are all the things that might be going on in the background that we might not really be seeing or understanding. So what I hope to kind of go through today is a basic framework of how we can assess sexual health in the clinic. We can offer basic interventions and then refer to a specialist when needed. So one question I get a lot is, how do you bring up this conversation? It can feel awkward or uncomfortable. And I think one of the easiest, one of my favorite tools to use is something called a ubiquity statement, which serves to normalize this conversation by simply stating, this is common. So sexual health concerns are common after someone has been diagnosed with cancer, or people on aromatase inhibitors frequently experience vaginal dryness, or many times after radiation, there can be pelvic changes. And that just really sets the stage for, as a medical professional, I'm comfortable talking about it, I'm bringing it up, and the fact that I'm bringing it up means there's probably something we can do to help. One of the common changes that can occur is called the genitourinary syndrome of menopause. And this is the result of lowering or changing of hormones on genital and pelvic health. And it can include dryness, decreased lubrication, discomfort or pain, even bleeding. Bleeding would always have to be evaluated with a pelvic exam and a gynecology evaluation. But even people who are not sexually active and don't wish to be can be significantly impacted with irritation, burning, itching of the vulva, vagina, urinary symptoms, even UTI. So this is not just vaginal dryness, this is really a constellation of symptoms. And one of the non-hormonal methods to treat this, which we can all be counseling our patients about, is use of vaginal moisturizers and lubricants. And there's a lot of confusion about this, but the moisturizers are intended to restore moisture to the tissue regardless of sexual activity. So I hear from a lot of my patients, they tried a moisturizer one time, it didn't help, so they stopped using it. So really that ongoing education, how are you using it? What products are you using it? How often? And kind of sticking with that. And some products I really like to recommend are the hyaluronic acid containing moisturizers. And there's multiple, commercially available products for that. And then when it comes to lubricants, I think really just explaining the difference and being able to give our patients some, safe products to use and suggestions. So the water-based lubricants, I'm very picky about what I recommend because a lot of these have a lot of additives, irritants, they're not the right pH. So I have a couple that I think are good and I'll kind of stick with those recommendations. And then silicone-based lubricants are more slippery, longer lasting. And so for our patients who might be having these symptoms, sometimes they work better. And I think, I really can't emphasize this enough that just being able to have a simple, comfortable conversation with this can really go a long way. So our patient did initiate vaginal moisturizers with hyaluronic acid 5 days a week, and she did have some improvement, but she was still having symptoms. And so this is the point where we would be talking about the use of vaginal hormones. So vaginal hormones are really the first line treatment for genitourinary syndrome of menopause in the general population. But of course, with patients who have hormone-sensitive cancer, we're gonna have a little more nuanced conversation about it. These come in a variety of different forms: creams, inserts, rings, there's even tablets as well. And use of this in patients with hormone-sensitive cancer has been addressed by multiple professional medical societies, so we can always fall back on referring to what these societies counsel. And essentially, it's all the same. For women with hormone-positive breast cancer who are not responding to these non-hormonal methods, low-dose vaginal estrogen can be considered after discussion of risks and benefits. And many of these guidelines came out, almost 10 years ago. This American Urological Association guideline came out just last year and was their first guideline from the Urology Society about genitourinary syndrome of menopause. And they specifically address individuals with cancer, so we can also look to this. And say similarly, clinicians may recommend local low-dose vaginal estrogen in the context of shared decision-making. So that just means we talk about what does the data show, what does it not show, how are the symptoms affecting you, and what's your comfort with taking a hormone. And we always think about absorption. There's a lot of different things published on absorption of vaginal estrogen. This is just one graph that shows that while higher doses in the blue, which we don't use those doses anymore, have higher absorption, the ones that are available, 10 micrograms and 4 micrograms, have low systemic absorption at day 1 that lessens by day 14. So I think that's reassuring. And then recently, there have been multiple retrospective studies looking at this topic as well, which we can use in our conversations with our patients. And essentially, what they've shown is a Danish study showed that, let me go back one. Overall, out of all the patients who were diagnosed with breast cancer, about 4 to 5% used vaginal estrogen, and there was no difference overall in recurrence or mortality. However, the subgroup with aromatase inhibitor, they did note an increased recurrence. This study was done prior to HER2 treatment even coming out. The entire doses of vaginal estrogen were different. The practice patterns were different, so I don't think it's fully applicable to what we do today, but it's something we can talk about. And this was followed by another study that looked at over 42,000 patients, which showed overall no increased risk of recurrence, even among the estrogen receptor subgroup. And then we have data about mortality showing that the proportion who used vaginal estrogen actually had a reduced breast cancer-specific mortality. There was no difference among the estrogen receptor subgroup, and even the aromatase inhibitor subgroup, the people who used vaginal estrogen actually had improved mortality. So I think this is, not showing recurrence, but this is extremely reassuring for us to have in conversations with our patients. And then finally, another study, this was presented at ASCO, actually just the day before I gave my talk, so I quickly snuck it in here too, but looking at a SEER database study that showed that among women 65 and older, that those who used vaginal estrogen had an improved overall survival and improved breast cancer specific survival, and the longer they used it, the better the survival. So this doesn't mean it improves survival. People who are healthier might be, more sexually active and wanting to use these products, but it's adding to this body of information about how, reassuring this is. So our patient, after discussion about what was known and not, initiated low-dose vaginal estrogen. Her dryness improved, but she was still having pain. And here's a really important point I want to make, is that not all pain is due to dryness, and that pelvic floor dysfunction is a really prevalent and common source of pain. And we see this not only among people with hormone-sensitive cancers, but anyone who's had a pelvic surgery or pelvic radiation, or really a multitude of different causes. And for this, I work very closely with our excellent pelvic floor physical therapists who can really dramatically change our patients' experience with this. One of the tools they may utilize is something called a progressive vaginal dilator, which a patient would use herself, 5 to 10 minutes a session, 2 to 3 times a week, and that can help with stretching and help with pain as well. So our patient did go to pelvic floor therapy, and she was able to have penetrative intercourse without pain for the first time in an extremely long time. And so this is really to underscore that when we ask about it, when we treat these patients with this biopsychosocial approach, we do see improvement. So now the next issue is pain is better, but she has no libido. And for her, breast and nipple sensation was important, and after bilateral mastectomies, that was now absent. And so, this actually low desire in the study that we did was the number one most common symptom. And so this is something that can be very impactful to people. And other people, it's not a concern to them at all. And so part of what I do when approaching low desire is talking about some differences between what's called spontaneous desire versus reactive desire. It's very helpful to work with our psychosocial team as well as specialized sex therapists. And there are even some medications that are there for low desire. Now, the first two, flibanserin and bremelanotide, are specifically FDA approved for premenopausal women with a condition called hypoactive sexual desire disorder, which doesn't fully apply to our patients diagnosed with cancer. But there has been, go over this. There has been a single-arm study of flibanserin in individuals with breast cancer who are on aromatase inhibitor and showed improvement. So I think this is early data, but there is something that we can talk about. And then another concern that we commonly see is issues with body image. And so I think it's important to talk about this and to offer resources such as counseling. So our patient did work with a sex therapist, and a lot of the issues were related to grief, a sense of loss of many things, including her experience with sexuality, her breast and nipple sensation, body image, different things like that. And then she and her husband worked together with couples counseling as well. And when she came back, this is something one of my patients has said to me, a part of me I thought was gone forever has been restored. And I think that just really goes to how important addressing quality of life and sexuality as a part of quality of life can be for our patients. So in summary, something we can all do is talk about it, ask about sexual health, offer basic interventions in the clinic, whatever feels within our scope, and then refer to specialists. And so some of the basic interventions, again, include moisturizers, lubricants, discussions about vaginal hormones. I mean, as oncologists, we're prescribing all these brand new medications that have extremely complex mechanisms, but somehow vaginal hormones sometimes seem scary, but they're really not. So in my talk, and as well as in the chapter, we have information about doses that can be prescribed, and then counseling about vaginal dilators, and then the specialists that we work very closely with, psychosocial, pelvic floor therapists, pelvic health specialists like gynecology, urogynecology, urologist, GYN oncologists. And then for people who have menopausal symptoms, who don't have hormone-sensitive cancers, really thinking about, did we induce a premature menopause? Should we be talking about hormone replacement therapy or menopause hormone therapy with this patient, and working with the hormone specialist? And for people who have multiple sexual health concerns, I'm here with the sexual health program, and we can always do an assessment. And that's it. Any questions? Yes.
So first, that was incredible. Thank you for bringing this is an important topic. I think we all so focus on curing people that we forget the quality of life. And I think kudos to you. I can't even express how important that is. Oh, thank you. Don't sneak up on me like that. Could you just maybe talk about how should we as a group be looking at, I think there's still going to be some reticence to use vaginal hormones just because of the fear, you had breast cancer, and what should we be doing to make sure that everybody understands that, not only the physicians and the caregivers in our clinics, but also the patients, because I sense that they're a little nervous of that.
Yeah, that's a fantastic question. So thank you for bringing that up. So I think that, what we probably all have outside of the clinic known and experienced is this sort of understanding going back decades that hormone, some negative impressions about hormones. But truly there's a huge focus medically right now about kind of trying to understand truly what the role of hormones does in a positive way, what are the true risks, and acknowledging that some of the fears that were there before may not have been founded or accurate or relevant today. So I would say, for one thing, is when we're considering all of our female patients where we might be talking about vaginal estrogen, there's going to be the majority that do not have a hormone-sensitive cancer. So in our lung cancer clinics, in our hematology clinics, and so forth. And so, there is great data showing that use of low-dose vaginal estrogen does not cause a higher risk of breast cancer in individuals who do not have breast cancer. And so that, I think that is pretty solid, and that information has been published. So for people who have a non-hormone sensitive cancer, then this is something we can be talking about and thinking about. Then for people who have hormone-sensitive cancer, I kind of divided up between, was it a history of breast cancer in the past, maybe 5+ years ago, and they're not on endocrine therapy now. I think those patients are very well represented in those retrospective studies that I showed. Then we have patients who are on tamoxifen, and none of the studies those retrospective studies showed an increased risk with tamoxifen because that acts more as a blocker. So even if there were absorption, I think really that shared decision-making conversation comes into play with our patients who are on aromatase inhibitors and vaginal estrogen. So I think kind of just zooming out a little bit and kind of understanding where is this patient fitting among the spectrum here. All right, any other questions? Thank you so much.